Here's one of the highest yield vascular emergencies on step 3. And a few critical decisions in the first minutes can determine whether this patient survives. This is aortic dissection, a catastrophic vascular emergency where rapid diagnosis and blood pressure control are critical because mortality rises hour by hour without treatment. The first priority is immediate stabilization. Start immediately with oxygen, pulse oximetry, intravenous access, and continuous cardiac monitoring. This patient belongs in intensive care level monitoring from the start. Perform a focused cardiovascular exam, paying close attention to pulse deficits and blood pressure differences between arms. As you continue the initial assessment, look for sudden tearing chest pain radiating to the back, unequal arm blood pressures, a new diastolic murmur from aortic regurgitation, or signs of shock and malperfusion. Continue frequent blood pressure monitoring and reassess pulses repeatedly. Once the patient is stabilized, shift your attention toward confirming the diagnosis. Even though this is a vascular emergency, still perform chest pain rule-out testing with electrocardiogram and troponin because myocardial infarction is a major mimic. Obtain chest X-ray, which may show a widened mediastinum. The key confirmatory study is CT angiography of the chest. In unstable patients, transesophageal echocardiography is preferred because it can be performed rapidly at bedside. Send complete blood count, comprehensive metabolic panel, coagulation studies, and type and screen because emergent surgery may be required. As the diagnosis becomes clearer, treatment should begin immediately. The highest yield CCS management step is blood pressure and shear force reduction. Start intravenous beta blocker first, usually esmolol or labetalol. Only after heart rate is controlled should you add vasodilators like nitroprusside or nicardipine if blood pressure remains elevated. This sequence is critical because starting vasodilators first can worsen the dissection by increasing reflex tachycardia and shear stress. Provide intravenous pain control with morphine or fentanyl and obtain emergent cardiothoracic surgery consultation immediately. Looking ahead to disposition, type A dissections require emergency surgery and intensive care admission. Even medically managed dissections require intensive monitoring. Before finishing the case, remember several critical CCS traps. Never give aspirin or heparin until dissection is ruled out because it can be catastrophic. Do not start vasodilators before beta blockade. Avoid wasting time with MRI and unstable patients. Remember, beta blocker first, then vasodilator. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content, and let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.